Good morning, everyone, and welcome back to our Community Health Profile launch for 2024. This is the third of our series of 11 webinars, where today we're going to be looking at some of the key health inequalities that we identified in our Chinese Community Health Profile, and then go over some next steps, key learnings, and some of the upcoming funding opportunities that we have available today. So if I just go through the quick agenda, we're going to spend about 5 minutes just getting into the session. We will be using Menti today as well. We should have been able to find a way that, in theory, you should all be able to see it on your screen, so you shouldn't have to go to an external app. You should be able to answer any of the questions or see any of the responses directly on your screen. We're then going to spend about 5 minutes going over the community health profile kind of introduction, so looking at how data was gathered, what some of the limitations are to collecting health data on the Chinese community, and a little bit about the overview of the demographics and the geography of where the population in Birmingham is. And we'll go through about 20 minutes of looking at some of the key health inequalities in the community health profiles. And before we even start looking at any of the data, I just want to make it really clear that because we've got a limited amount of time today, that it's not going to be a complete, comprehensive understanding of every single health inequality that the Chinese community may face. And also I want to highlight that it may not necessarily be the areas of health inequality which are most important or most prevalent for the community, but it's just these are some areas where we had the strongest data that we're able to present and talk about in a lot of detail. We've then got some key kind of takeaways, how you can take these findings away into your practice, especially if you work in a healthcare setting in public health or NHS representative or in a community organisation. And then we'll talk a little bit about our upcoming 2 funding opportunities that we've got to work with the Chinese community. And then we should have around about 10 minutes for any Q&A at the end of the session. So just before we jump into it, just some quick housekeeping, fairly standard for anything for a webinar. I just suggest that if you stay muted and turn off any VPNs to help things run smoothly. It's not saying that you have to be quiet the whole session. If you've got a question, feel free to mute yourself and ask. It's just while we're speaking to make sure it goes smoothly, but just kind of mention that. There should be a Q&A feature on both Menti and in the Teams chat if you'd like to ask a question at any time. The Mentimeter will be anonymous, so there should be a button that says Open Q&A. However, if you prefer to kind of put your hand up and ask a question, turn camera on, it's up to you how you want to ask questions and engage with the webinar. There's no pressure either way. These slides will be sent out over email to everyone that signed up to the Eventbrite page, but they'll also be hosted on the Birmingham City Council webpage alongside the other resources for the Chinese Community Health Profile. And the webinar is being recorded and will be up on the Healthy Brum YouTube channel, hopefully either by the end of today or tomorrow at the latest. So just a little bit about the community health profiles as a whole. I'm not going to spend too much time going through them. We will get on Menti first as well. There should be, as I said, on Teams, a way to get onto it. But for those that haven't been able to access it on Teams, Reese, if you could pop in the joining instructions on Menti, you should be able to either go to menti.com and enter in the code 25384440, which Reese should pop in the chat. But you should, in theory, be able to see it on Teams, so you shouldn't have to go to an external platform as well. And if anyone has any issues with joining, please let me know. So before we kind of jump into it, let's see if kind of Menti is working today. Hopefully we're not having any tech issues. But for the people in the room today, is there anything you're particularly looking forward to learning today or discussing in today's webinar? If there's anything that kind of comes out as a recurring theme, I can make sure I spend a little bit more time focused on one area if there's a particular interest in the room on it, if it's something that's already in our slide set or something we can focus the discussion topics on at the end. So I'll just give that a second and hopefully it works through. So we've got someone just looking for a summary of health inequalities, another one looking at health inequalities, how data's gathered and the sources. Okay, yeah, I'll talk a little bit about that as well then, if that's something that's interested in the room. And if you're looking for a summary of the health inequalities, looking at kind of the perfect webinar for that then. Perfect, thank you. So moving on. Little bit about the community health profiles. So for those that aren't aware of the profiles, I'm not going to spend more than about 5 minutes going over them, but they're a key set of resources that have been developed by the Public Health Division at Birmingham City Council over the last couple of years. And the Chinese Community Health Profile is one that we've launched in the last couple of months. And these reports look at summarising the physical health, the mental health, the lifestyle, the behaviour, and the wider determinants of health-related issues in a specific community across the life course. So the profiles start with a section on getting the best start in life, go through to aging and dying well, and focus on different aspects of health. For example, we have an active at every age and ability section looking at physical activity, a healthy and affordable food looking at diet and lifestyle. And these profiles focus on specific communities of identity because we want to shift away from using acronyms such as BAME, which homogenise communities together and often overlook those huge differences in health inequalities and health outcomes between different population groups. So if you just looked at, for example, in this case, the broad Asian ethnic category, the health needs of someone that's potentially from the Chinese community is going to be very different from someone that's from Indian community. So it's why these profiles we've tried to look at as specific health data as possible. It's not always available to have the data in that way, and that is one of the limitations we'll talk a little bit more about. We have two kind of key resources available at the minute for the Chinese community. So there's the full report, which is about 100 pages long. They're quite lengthy documents and go into a lot of detail. This webinar today will kind of summarise the main parts in each of the section of the reports. We also have a quick infographic summary, which is just a one-page visual, really short to look at kind of key points across the profiles. I know there was someone in the webinar that said they're interested in the data and the data collection methods. We have a whole intro to community health profiles video, which talks specifically about how the profiles were developed, looking at the journals that were investigated, the search terms that were used, and a full search strategy in each of the profiles is available. So you can see the specific search terms for the Chinese community that we inputted into the Ovid database to investigate our different research journals and different databases. That's all in the intro to community health profile videos. We predominantly looked at using the national data sets where possible. So we focused a lot on the census, a lot on things like the NHS digital, GP patient survey, but we did also combine that with smaller specific community-based research to make sure that we had multiple data kind of sources backing up the same points to make sure that we had a comprehensive understanding. And we didn't make too many assumptions by just using one data source from throughout. So we'll talk a little bit more about data in terms of how we included people in the profile and what some of the considerations are if you're a healthcare professional and wanting to maybe work with the Chinese community. In the 2021 census, it was one of the ethnic groups that was in the top 20 ethnic categories within the Asian kind of overall group. There was a specific ethnic category for Chinese, which meant we were able to do a lot of that multivariate analysis, meaning we could investigate things like Chinese ethnic group by housing, by education, by general health. So there's a lot of data that we could get from the census, and a lot of those other national data sources like the like NHS Digital in terms of the health survey for England look specifically at the Chinese ethnic group. Not always is data on ethnicity available. So in some instances, country of birth has been included instead, but obviously that's going to be limited understanding because that's only going to look at first generation migrants. Now, there's some other data considerations that I've put on screen here to consider when engaging with a specific population. And this isn't exclusive to the Chinese population, but it's just something that I want people to consider, especially in healthcare when making decisions, that someone's ethnic identity isn't going to be the only factor in how they engage with healthcare services and their specific health needs, and that those individual approaches are going to be really important. And I've put some of the other data that may be useful. So if you look at someone's country of birth, length of residence in the UK, English proficiency, you're going to get very different situations for healthcare needs depending on the answers to these questions. So, for example, the health needs of a recent Chinese migrant that has limited English language ability is going to have significantly different healthcare needs and different knowledge of the NHS and the available services compared to someone that's from a Chinese ethnic background who's born in the UK or born in Birmingham, speaks English as a main language and has grown up with the healthcare services. It's going to be two very different population groups. So just to consider that ethnic identity is not the only kind of important factor when considering healthcare decisions for a specific community, in this case, the Chinese community. Now, last little kind of bit about the data analysis before we get into actually talking about the Chinese community is just some of those limitations that we've come across when trying to get that picture of health and well-being. In some of those smaller data sets, there is a wide variety of how the Chinese ethnic group has been categorized, and often it's put into the other Asian or just other ethnic group categories, which really doesn't give us a clear understanding of the specific health needs. And because of these different groups that the Chinese population is often categorized into in those different data sets, it makes it really difficult to have that effective analysis of those health and wellbeing needs when we have that inconsistent use of ethnic group categories. And one thing just to consider as well is some data sets like the GP patient survey don't have, or they have unadjusted variables, which means when we look at the outcomes, they may be slightly influenced by other demographic factors like the age or the gender distribution of a population. So now we can talk about the actual data within the Chinese community. So I'm going to start with just a broad demographic overview. And this is for the Birmingham population specifically. It is slightly different on a national level. So, for example, the population size, 1.1% of Birmingham's total population is Chinese, but that is higher than the England and Wales average, where the Chinese population make up 0.8% of the total population. So there's around about 13 or 12,500 people in Birmingham that checked the census ethnic category for Chinese under the 2021 census. And some of the other data that came from that census about this population were on religion, age, English proficiency, national identity. There was a whole host of demographic factors that we got. I've just put a couple of kind of the key headlines on screen that might kind of be useful to understand kind of who our population is when we're looking at them. So in terms of religion, there is a really high proportion of people that ticked having the no religious identity compared to the Birmingham average. So it's about 40 percentage points higher than the Birmingham average. Only about a quarter of the Birmingham average population said they had no religion, so compared to 64% of the Chinese population. The two next most common religions that were identified were Christian at 16% and Buddhist at 9%. In terms of the age demographics, overall, the Chinese population in Birmingham is much younger than the Birmingham average, and about half of the population is under the age of 35, compared to only 39% of the Birmingham average. And as you can see by the graph on the left, there's a big spike in the age of 18 to 24. So there's a much larger proportion of the Chinese population falling into that age demographic. In terms of English proficiency, just under half had English as a main language. And of those that did not have English as a main language, 35% could speak English well or very well. And there was only about 15% that could not speak English well. But considering when you relate this to the total population of Birmingham, only about 4% of the Birmingham average population could not speak English well. So it's more likely that the Chinese population in Birmingham is not going to speak English well or very well, if not having it as a main language. And with national identity, what we tend to see for across any ethnic group or any country of birth, that people that have been in the UK, whether it's for a couple of years or their whole lives, at least half of the population identifies solely as British only, and that is seen kind of across the profiles. It's really interesting to kind of note that the majority of people in kind of most different community of identity that we look at tend to identify with the country that they're currently in. Now, one thing that I want to highlight with demographics with the Chinese population on the next slide is about the length of the residents in the UK, as there are two kind of very separate and large population groups that related back to when I talked about those other considerations of having different health needs. So around about a quarter of the Chinese population in Birmingham were born in the UK, so this equates to around about 3,000 people. But of those that were not born in the UK, we see a huge split based on the pie chart on the right. So almost half of those that weren't born in the UK, so 46%, have been in the UK for 10 years or more, so a large amount of time, and this is around about 4,000 people. But there's also a huge portion of the population, so 36% of those that weren't born in the UK have been in the UK for less than 2 years, so are really recent migrants. So it's that huge split between Chinese population that is really new to the UK and those that have been here for decades or their whole lives or generations. So there's that big split, and it's going to have very different implications for interaction with healthcare services and healthcare needs. One other really useful thing that the census gives us a bit of an overview is geography. So it's really useful to look at place-based community events or health interventions. And this gives us a bit of a visual representation to where our different populations are in the city. But just a quick thing to note that the places where people live may not necessarily always be the places where community engage. And that's why it's important to use a mixture of that data-led approach from the census, but also talking to the communities and using that community intelligence as well. Now, the census mapping tool, if you've not used it before, I'd highly recommend having a play around. It's really useful to have a look at. And for ethnic group, you can look as small down as output area level, which is really small neighbourhoods consisting of around about 300 residents. And across Birmingham, the population density of the Chinese population varies significantly. So in some areas of the city, less than 0.1% of the population is Chinese, but in some of these small output areas, 2/3 of the population are Chinese. So there are pockets of high population density, primarily in the centre and the south of Birmingham. So the three highest, most densely populated MSOAs are Digbeth, the Central MSOA, and Selly Oak. So in Digbeth, it's saying that 13% of the overall population is from the Chinese ethnic group, compared to that 1.1% of the overall Birmingham population. For those that aren't familiar with the term MSOA, this is just a slightly larger area. It's a middle super output area, and this is around 2,000 to 6,000 people. And these data is just useful to be able to get that smaller community level data rather than just looking at ward or constituency level. Now, we're going to go through a couple more of the Menti sections, and then we'll go through some of the key health inequalities across the different sections of the report. So I think we have two quick questions now. So I just kind of want to understand before we go through the data in the room is what people's overall knowledge currently is, and looking at how confident you feel in identifying the health needs specifically to the Chinese population compared to other ethnic groups. So whether or not in general we have a good or we don't have a very confident level of understanding in the room, and this will kind of just help me know what level we're at and kind of roughly who's going to be in the room with us. So it looks like we're pretty much in the middle, kind of floating around that 2.5 to 3. So people are kind of somewhat confident, but hopefully maybe looking at these kind of key inequalities across the different areas of the life course will help us increase that confidence, and maybe we'll reiterate some things we already know, or maybe we'll give us something new. When we do go through the different inequalities, I'd like people to kind of reflect on this from different perspectives. So if you're a healthcare professional and you potentially don't work with the Chinese population very often, I want you to think if any of the data surprises you, if anything matches up with kind of your previous experience. If you work frequently as a community organisation, or you yourself are a community member, and think, is this data reflective of my own experience and my own previous work or my own life? And this is something that we can factor in the discussions at the end. And also these profiles are not finalised. So actually, if you're someone that is from a Chinese background that looks at this and go, actually, this area of health is really important to me and is not discussed today, that's definitely something we can look at kind of integrating into the future and making sure that these are kind of an accurate portrayal. So the next question as well, we're going to quickly look at how people currently use health and wellbeing data to make decisions related to addressing health inequalities in the Chinese population. Now, as the knowledge in the room was a bit mixed, it may be that you currently don't use data in this way at all, and it's something that you're looking to learn as a start point, and that's absolutely fine. So if the answer to this question is I don't, there's no kind of judgment. This is a good start point, but it may be that if someone else does frequently use data to inform decisions for health inequalities, it may be useful to see how people do that to gain a little bit of inspiration. So I'll let that go just for a kind of a second or so, and then we can get started with the health inequality data. Yep, definitely still looking at organising talks and events, and I assume those talks and events will be around the specific topics that are available in the data. Absolutely. Right, I think we'll move on, but you should be able to still answer this question while we're going through the next couple of slides, so we can always kind of reflect back at the end. So we're going to just look at, as I said, one key kind of section of data in each section of the report. I don't want it to be too overwhelming and bombard you with every single statistic that was in the profile, because as I was saying, it's like 100 pages long. So to absorb all of that in an hour is impossible. So as I was saying at the beginning, for those that have kind of joined a bit later on, I'm going to be picking out kind of some of the data where we've got the strongest evidence. It's not necessarily saying that this is the most important health inequality or the one with the highest urgency or priority in the community. It's just one that we've picked up because there's that strong data. Potentially the data was reported specific for the Chinese community. It didn't aggregate it. It was a large population data set. Those are the kind of things that we're kind of focusing on. And it's not going to be that comprehensive, complete understanding of all health inequality needs that relate to the Chinese community. And hopefully for those that are interested after this webinar, it'll provide a nice start point to going and doing further reading and further understanding. So the thing I'm going to start off today is the Getting the Best Start in Life. So this focuses primarily on children and young people. And one of the sources of information that we've picked up here is the Oral Health Survey of 5-year-old Children report. And this is looking at an England-based level. And it actually found that Chinese children were more likely to experience dental decay across England compared to almost all other ethnic groups apart from Eastern European. And what we examine as prevalence of dental decay is any visible teeth that have obvious signs of dental decay on them. Overall in England, around about a quarter, so 23% of children had this experience of dental decay. But amongst Chinese children aged 5, it was the second highest, and 42% had experience of dental decay. There are some small qualitative research that also backs this up. We used in the report, there was a small study of 18 Chinese mothers who had recently migrated to Northern Ireland that suggested that dental decay in children was viewed as inevitable, and it created some barriers when discussing the need for preventative dental care. This trend, interestingly, wasn't mirrored in the adult population. The oral health of the Chinese adult population was not seen as poor at all. But it's important to discuss the benefits of oral health among children. So good oral health can support children's overall health, the cognitive development of children, and dental infections in youth can often lead to later chronic medical conditions. And poor dental health can affect other aspects of well-being, like feelings of self-worth, happiness, and also has been linked to an increased tendency to feel or act shy in children that have experience of dental decay. So although the trend is not mirrored into adulthood, the experience of children and child oral health was still an important aspect that we picked up in the profile to make sure that it was discussed. When we picked up on mental wellness and balance, we looked at the Health Survey for England, which focused on WEMWEB scores. So that's the Warwick Edinburgh Mental Wellbeing Scale. And this is a questionnaire of 14 total items on a scale of 1 to 5 that captures feelings of wellness in a general sense. So looks at statements such as I've been thinking clearly, I've been feeling loved, I've been interested in new things, and rates them from us. And I like it scale from strongly disagree to strongly agree. And although the differences of 1 to 2 score points is quite minimal when you're looking at between individuals, the Health Survey for England is a very large data set. So when we have those small differences in a population, it could indicate a potentially larger issue. So what was quite interesting is on average, the Chinese population scored higher than the white British average population in England by only half a score point, but in general showed better scores on the mental wellness scale. However, when we look at breaking it down further and look at the differences in gender, the data becomes, we get two completely different stories, and that Chinese women had much higher scores on the WEMWEB scales than white British women. But Chinese men scored the lowest across all ethnic groups. And this isn't just mirrored in the Health Survey for England. There was other smaller studies. So for example, in the profile, we touch on a study in Coventry that looked at different Asian subpopulations and looked at the scores between specifically Chinese population and Pakistani populations, and again saw that lower mean and median scores in the population groups. Now, what was interesting to see is among both Chinese men and women in the Chinese Community Health Profile report is that regardless of the scores of mental health and well-being and the perceived mental wellness, there was a lower uptake of mental health services of the Chinese population compared to the white British population, which on the surface you may assume means that there's the lower need for mental health services. But actually, when you delve a little bit deeper into the data, we find that the Chinese community also has one of the highest rates of compulsory admission to mental health services. And some of that qualitative data actually shows that the population doesn't necessarily engage with NHS and kind of those statutory mental health services until in crisis situation. So just something to consider if you're a mental health professional or work in healthcare, that just because a population has particularly lower uptake of a service doesn't necessarily mean that the need is lower, and kind of just important for that to consider overall, that there's going to be lots of different factors that can contribute to someone's desire to interact with mental health services versus the need to access those services at a particular time. Now, moving on to healthy and affordable food. One thing that I've covered in this section is obesity, which actually, when you look again at the general overall picture, the Chinese population in both Birmingham and England and Wales has one of the lowest overweight and obesity prevalence rates. But I just wanted to touch a little bit on BMI and the implications and some of the other, again, qualitative findings and some of the suggestions from the World Health Organization. So BMI, when we look at it as a measure of health, it looks at height and weight to give an estimated weight status. And in general, the NHS states that anyone with a BMI of 25 or over is considered overweight. When we look at how that compares to the Chinese population, for men, it was on average 24.2 and for women 22.9. So on the surface, it looks like the Chinese population is at low risk for being overweight or obese, which that in itself is true. However, when we look at BMI as a tool, it is quite limited. It doesn't take into consideration different ethnicities, different ages, different sexes, and actually is quite limited when looking at populations outside of that standard white British approach. And the WHO investigated the BMI thresholds for Chinese populations and actually said that the at-risk category should be set to 23 due to the increased risk of diabetes in the population at those lower BMIs, which if we compared the BMIs now in the Chinese population to that WHO guideline of 23, it may suggest that the Chinese men are at that slightly increased risk for other conditions such as diabetes. So should be considered as well as just that standard BMI benchmark. There are other measures as well that can be included, including waist circumference, waist to hip ratio, body fat percentage. But again, they're typically aligned on that very standardized approach and don't necessarily give that comprehensive understanding of the risk of different health conditions in a specific population group. So just something that I wanted to highlight, as I found it quite interesting when I was writing this report, the limitations of BMI and those, and that doesn't necessarily mean specific health outcomes. Okay, moving on to active and at every age and ability. So we're looking at physical activity here. So according to the Chief Medical Officers for England and Wales, the definitions of activity are measured by either 150 minutes or more of moderate physical activity a week. And moderate activity classes as anything that raises the heart rate. So this is a brisk walk, cycling, anything that gets us out and about and moving. But you can also be classed as physically active if you do 75 minutes or more of vigorous physical activity per week. And this can be anything that's high intensity. So running, for example, is a vigorous physical activity. Now, overall, in the West Midlands, the Chinese population were slightly less active than the white British population. So 51% of the Chinese population met those physical activity guidelines compared with the white British population. And what the Active Life survey also provided us, which I found quite insightful, was different fitness activities and how popular they were among specific community groups. So it doesn't necessarily show the most common sports on the right here. It shows what the population is more likely to engage with than the total population. So actually, in the Chinese population, the most common physical activities were things like walking for travel, walking for leisure, running. 20% of the Chinese population in this study said that they ran on a regular basis. What this list on the screen is showing is where there's a higher percentage of the population that engage in this sport compared with their total overall percentage population. So what I mean by that is when we talk about badminton, in England, it was the Active Life survey was saying that 3.2% of all people that played badminton were from a Chinese background, which doesn't sound like a large amount, but when you consider that the Chinese population made up 0.8% of the total England and Wales population, proportionally, they were more likely than the average population to take part in that activity. So any sport that was classed as more than 0.8% of the total sport population were Chinese were listed as a popular fitness activity. And this is the same for other ethnic groups. So what was listed as populations where the total share was higher among the Chinese population were things like badminton, table tennis, general fitness training, so things like weightlifting in the gym, combat sports, and again, running. So now we'll move on to living, working and learning well. And I wanted to highlight the employment and the economic activity. Again, just to bring a little bit more context to some of these things, to show that the health and wellbeing needs aren't necessarily just as black and white as they look on the surface, that when you look at it overall, the Chinese population actually had quite a high percentage of people that were economically inactive. Again, this is in Birmingham compared to the total population. But of that 50% that were economically inactive, 29% of the Chinese population were classified in the last census as economically inactive full-time students, which compares to only 10% of Birmingham residents. So there's that big difference there. And that also is reflected in that data where we looked at in length of residence in the UK, that there was that big percentage of the population that had been in the UK for less than 2 years. There is some correlations to show that a large percentage of these might be students that are over here for higher education studies. The census also breaks down quite usefully the top 101, I want to say, occupations. So again, if you want to do kind of specific interventions, it's useful maybe to know people's working patterns or industries they're working in, and it provides the total percentage of the Chinese population that work in specific industries in Birmingham. Now, although those aren't health inequality data, it's just useful to know. But one thing I wanted to focus on that the report highlighted is those different barriers to employment, because good employment is one of the biggest wider determinants of health that can influence that overall health and well-being. And there were some stark inequalities within the Chinese population to employment. So older Chinese migrants typically faced additional barriers to employment. There was a higher proportion that had worked in self-employment previously, or worked in precarious careers, which made it difficult to apply for more senior positions, with employers looking for like more formal qualifications and backgrounds. So there was those barriers among the older population. There was also big inequalities found in pay inequality within the same industries. So one of the studies highlighted in the report found that migrants from mainland China had on average a pay of 21% less than the white British counterparts in the same industries. So that experience of poor employment is going to be much higher among the Chinese population. Typically, those that were British-born Chinese had better pay than those that were Chinese migrants, but all Chinese populations had worse pay outcomes in the same industries compared to the white British counterparts. So that inequality faced in employment and potential discrimination faced in employment in the workplace was one of the big barriers that we identified in this report. Now, if we move on to protect and detect, one of the areas of work that we looked at in here was infectious disease, and one of the diseases that we picked up in here was prevalence of hepatitis B. So it was difficult to again find national data sets because there was no standardized data set that showed a breakdown by ethnic group. But through a couple of different reports, I think we've included 4 different studies that found relatively similar outcomes. There's a approximation that Chinese adults were at higher risk for hepatitis B. So roughly over the couple of studies, the prevalence was around about 9% compared to the UK average prevalence of around about 0.1 to 0.5%. And some of the qualitative findings backed up saying that there was a lack of knowledge on the transmission and the causes of hepatitis B, and some of the participants in these studies cited that a weak liver caused hepatitis B rather than the other way around. And the studies actually suggested that a targeted hepatitis B screening and support for the Chinese community could potentially detect up to 30,000 cases of hepatitis B nationally. So there's a big potential gap in screening programs here. And again, this prevalence was significantly varied based on country of birth. So on the right here, it talks about country of birth of those that identified their ethnic group as Chinese in the studies. So again, it varies significantly between the UK and those born in different parts of the world. So for example, the Chinese population that was born in Vietnam in these studies had a prevalence of around 17%, whereas those that were British-born Chinese had a prevalence of around about 6.7%. And even though the difference, if we compare maybe mainland China and the UK, is only a 4% point increase in difference, and it doesn't look that significant. If you actually look at that as a percentage difference, there's a 65% increase in those from mainland China having prevalence of HBV compared to Chinese population born in the UK. So there's those big differences again based on country of birth. So again, tying back to that thought at the beginning of the webinar that just looking at one sector of someone's identity, regardless of what community we're looking at, is not going to be enough to effectively understand the health needs. And looking at ethnic identity versus country of birth, also looking at other intersectional aspects of identity like age, like sexual orientation, like disability, are all going to influence and have those different compounding health inequality needs across these different areas. Now, finishing up, I haven't included any highlights from the ageing and dying well section because there was such a limited amount of data specifically on the Chinese older population. And the only statistics that were found was about high risk of loneliness, which I'll touch on in the next slide. But that is not specific to older populations only. So there's really limited understanding, and that's a big gap that we've kind of identified for future research, is looking at older adults. The last thing that we kind of looked at in this report is contributing to a green and sustainable future. This is experience of things like access to green spaces, experience of air pollution, because air pollution is a major public health risk. And it was estimated in 2021 in Birmingham that around about 6.2% of all deaths were attributed to air pollution in some way or another. So it's a huge public health concern. And as we saw in the census mapping tool, the Chinese population in Birmingham is primarily concentrated in the centre of the city, where pollution is generally higher. And when we map that area of residents from the census to the air pollution in these different MSOAs, we can approximate that almost a third of the Chinese community in Birmingham live in the top 15 most polluted neighbourhoods, compared to only 5% of the white British population. So actually, experience of air pollution and poor air quality is something that we identified as being one of the highest, I think, in the Chinese community out of all of the 11 new profiles that we analysed this year round. So really stark difference there. Now, I know it's been kind of a whistle-stop tour and I've kind of thrown a lot of information at you. There are some other key inequality data and considerations that we had throughout the report. I've put a couple on screen, but again, that's not a full list of everything. So, for example, just to list off a couple of the statistics on screen, the preschool development was low among girls in Birmingham. This is looking at the academic year of 2018 to 2019 of those finishing reception. So it was based on the early years development. And it was saying that only 70% of Chinese girls reached those expected development levels, compared to 74% of all girls in Birmingham, where it was actually flipped for the opposite gender. So Chinese boys had the highest level reaching that expected development goals compared to the other ethnic groups. That didn't seem to impact on GCSE and A-level attainment, so it was purely just that preschool development. We talked about previously before that low engagement with mental health services, and the specific statistic that I've got was that 67% of the admissions in, that 67% the Chinese population was more likely to go through compulsory admission compared with the general population. And again, talking about it might not be reflective of the overall situation. We've got high levels of loneliness and social isolation. So we looked at a study that looked at a particular scale for loneliness, and compared to all other ethnic groups, there was much higher rates of loneliness and social isolation. There was also high rates of TB among, again, migrants. So we look at the rates per 100,000. For UK-born Chinese populations, it was only 2 per 100,000, the rate of TB. But for those that were non-UK born, it was 21.3 per 100,000. And this wasn't the highest of all of the communities born not in the UK, but it was a trend that mirrored through almost all ethnic groups, that those that were born in the UK versus not born in the UK, those that were not born in the UK had a much higher rate of things like TB. So again, going back to that same point, that ethnicity is not the only important variable when talking about someone's health and well-being. Now, I know I've kind of spoken at you for a while, so we've got a little bit of Menti again now. I think we should have another rating of, hopefully that improved your understanding of the health inequality needs at least a little bit. It's probably not, you're not going to walk away and go, yep, I'm 100% confident now, and I wouldn't want you to. I'd want you to kind of take this as a first step to going, right, I now want to go and learn more about this particular area that I heard about today. But I'd just like to see, did you feel that overall this gave you a good overview of identifying those specific health needs? So we're still around kind of that middle mark, but I think we're ever so slightly higher. I would highly encourage anyone that has come along today and has found it useful, but still doesn't go towards that very confident area, to go and read the full report, or at least specific sections of the report in areas that you work in or have a lot of interest in, as it does explain all of these points in a lot more detail, provide a lot more different references and sources to go and kind of have that snowballing and that further reading. So I'm going to quickly just cover some of the kind of next steps and opportunities for action before we go into a little bit of discussion. So as I said before, the profiles are currently still being changed and edited and updated. They're all in their draft version. And the reason we've left them in this way is we wanted to make sure that before we finalise them and said, right, these are now, we encourage you to use them as they are, that we wanted to make sure that a variety of different organisations and people that work with the Chinese community or those that are Chinese themselves had the opportunity to have their voice in the report and say, actually, I agree with this, I disagree with this, and we are welcome and open to those conversations. If anyone reads the report and would like to give us feedback or would like to say that an area of health and wellbeing that is important has not been identified, please email us. Reese has just put our community's inbox on the in the chat. We will be also running some set feedback sessions. I've not confirmed the dates of those yet, but I'm happy if anyone wants to discuss it in the next like upcoming couple of days or weeks, that reach out to us, and we're more than happy to book kind of a conversation and make sure that we have those voices in the report. We have also mentioned that, saying if there's an area of health that we haven't researched, I just want to reiterate that the reports were made on a standardized template across all of the 11 profiles that we developed this year, just because of how much health and wellbeing data that there is out there and we could have included. We base the template alongside general public health priorities. But if there's a particular area in a particular community that we've not covered, we can do that on an ad hoc basis. If also you're an organisation that works closely with the Chinese community or offers specific healthcare services and you'd like your organisation details to be added to the profile so we can signpost people to your services or to your community centre, please reach out to us and we're more than happy to put that on there as well. We want to make sure that we're directing people to the most appropriate places to get support and health and wellbeing information and services. So quickly, just a bit of a checklist on what we can do following from today. So you kind of leave today with a bit of a clear understanding of what's the what next. So we suggest that you kind of share the information or the profile reports with people either in your team or your wider organisation. Do you know of any organisations that you partner with or just that you know through your work that work with the Chinese community that may benefit from reading this report, giving that feedback and maybe using some of those inequalities to help advocate for better services and better support for the Chinese community? Have you used some of the key inequality data in the report to reference the profile in a new project, to try and include some of those findings in project proposal to say we've identified this health inequality? So for example, we talked about that gap in screening. Here's the data. We suggest doing a targeted screening programme. Also using that influencing decision making with those relevant stakeholders by making sure you bring that voice in and you can advocate with that data-backed approach for the Chinese community to make sure that we're supporting all of our communities in Birmingham appropriately. And as I was saying before, and I'll just reiterate again, these profiles are a start point for developing services or interventions. They only really cover that headline data, and even though there's more detail in them, it's not going to be a full report for each section. So if you have a particular interest in, let's say, mental health, there will be information on mental health, access to services, mental health conditions. But if you're then really interested in, we would consider doing more research after that and community engagement as well. So not just relying on data, because again, data perceptions on a national level, which most of them are, may be different to the experience of a local population in Birmingham. So I think now we've got a little bit of time for some more Menti, just to have some of those conversations. We will have that kind of open Q&A at the end, but it's just again to kind of share some of those, how we plan to kind of use this going forward. So how do you think this might be useful for your work? And this will be useful for others in the room that are not sure again and want some tips on kind of where to go next. But it may also be kind of useful for helping us to guide our next steps to make sure that we can support the people that want to use this work and want to engage in this space as best as we possibly can. If you can't think of anything off the top of your head, don't worry, but it's just useful to kind of have the opportunity that we can ask them of these questions and make sure that we have those considerations in our work as well. So for example, if there's any public health colleagues on the chat, have you got any upcoming strategies? Oh, there we go, there's one come on the screen. The planning of targeted physical activity sessions. That's a great one, yeah, especially with those, the insight of those different physical activity, preferences, sports, community engagement, look at grant applications. Already referenced the mental health element, brilliant, that's really useful to see. Kind of further those discussions, those, again, those communication barriers, and just, I think that's kind of the thing that comes across all of these profiles is the need for all of us to kind of actively commit to making sure our resources and our services consider all of these different viewpoints throughout our particular work streams. Practical tips and background when seeing patients, yeah, brilliant, thank you. So next we'd like to just kind of see from kind of a personal perspective, how do you hope that the services will be more inclusive? So this potentially may be more relevant for organisations that work quite closely with Chinese individuals already, what would you like to see of the healthcare professionals that are potentially in this room with us? How would you like these healthcare services to be more inclusive, and make sure that we can kind of take these findings in a really relevant and culturally appropriate way going forward? Interpreters and tailored resources. Yeah, thank you for these responses coming through. Potential communication barriers. Yeah. I think that was one thing that highlighting in that first demographic section, off the top of my head, I think it was half of the population speaking this as a first language, whereas 15% may have those additional communication needs. So making sure that we assist appropriately and have those conversations to identify the specific need and where we might have need to use interpreters and those tailored resources. Again, yeah, having translations in traditional and simplified Chinese, having that cultural competency approach, definitely, thank you. And the last kind of Menti question for you before we wrap up and then do some open Q&A and discussions is there anything from a public health point of view that we can do, anything else that we can produce, any other resources or videos or anything that we can kind of do to improve your knowledge or make it more practical, help you support in your work going forward in supporting the Chinese community in Birmingham? Is there anything that we can do personally from this? Yeah, information directly from citizens, I think absolutely, when we talk about how there's a lot of gaps, especially at a local level, that thankfully will feed perfectly into the slide I'm going to talk about in just a second, where we're absolutely on board that, yeah, there needs to be more kind of citizen involvement and utilising of that citizen voice in these a carer profile. Thank you. We'll make a note of that as well. Yeah, there is in some of the profiles a little bit of information on carers. We generally get a little bit of information from the census on the amount of people that are unpaid carers, but there is kind of very limited qualitative data on a community specific level, but that's something we can definitely make a note of. Thank you. Okay, so following on from that, I'm going to talk quickly about kind of some of the upcoming opportunities that we have that the people in the room may be interested in either applying for or sharing as widely as possible. Is that we currently have 2 available contracts to work with the Chinese community. So the first contract that we have at the minute is a 12-month contract. It is live on Find It in Birmingham at the minute. Because of the contract amount, if you do not have Find It in Birmingham because it is behind a paywall, please message us again at the communities team inbox and we can directly send you the invitation to quote document. And that is a 12-month programme looking specifically at the engagement from the community health profile. So that will involve disseminating out the findings to various stakeholders, so particularly maybe NHS, other public health, other community organisations, looking at developing 3 small projects that tackle some of the inequalities identified in the profile. So that may be from doing some physical activity groups or having like a vaccine van or something like that, and looking at developing case studies of how people have felt their experience with the profile maybe reflects their lived experience, so we have that community voice. We also have a 3-year deep engagement partner contract coming up. Hopefully we'll go live in the next couple of weeks, we're hoping. And that is an initial 2-year contract with a 1-year potential extension that looks on really involving community voices and has that focus on sustainability and upskilling. So some of the requirements of that, if we go on to the next stage, the next slide, please, is predominantly looking at focus groups, again, led by community priority and what they'd like to see services become more relevant in, or whether we've got specific gaps in that localized data. They will be supported by an academic as well to help us make sure that we can then feed that information back to the relevant services and the relevant commissioners to make sure that they take those citizens' voice on board. We'll also be linking up the community organisations and community members with particular boards, so like the Creating the City Without Inequality Forum, to make sure that we have that community voice at a strategic level, that we have representation from different communities that can ensure that those decision makers, we platform them to have those decisions and make sure that the relevant services again use those community voices. There will also be the development of a significant health inequality project per year, and we will look at upskilling the community. So we have particular community leadership training at the minute. There'll be the opportunity to link in with our Bolder Healthier Champions programme. There's also potential opportunity to deliver training sessions on culturally competent care to different healthcare professionals, and potentially looking at other external courses in different areas of health and wellbeing to upskill community members, especially if you already have things like health champions programs, is being able to have that opportunity to do additional training and upskilling in the community where you might not have the current opportunity to. Now, just to close up, I know I've kind of overrun a little bit of our Q&A time, so I won't spend too much time on this. We do have 11 launch events in total. They will all go on our Healthy Brum channel, and our first 2 are already live on there at the minute. I think Reese will put the links in the chat in a minute if he's not done so already. And I would highly encourage you to, if you've enjoyed today, to sign up to our other upcoming webinars. Our next one will be held next week on our Gypsy, Roma and Traveller communities, focused on the findings from that community health profile. We also have an ongoing evaluation as well with community health profiles previously. So if you've used any of the community health profile reports in your work before, it would be really appreciative if you could take the time to fill out this quick survey to talk about your experience. If this is the first time engaging with the profiles, then don't worry about this section of the webinar. And it will be hosted by 2 of our kind of academic representatives. I'm just going to check if any of them are in this webinar today. And if so, I'll give them a minute to speak. I don't think they are, so we'll move on then to our Q&A and kind of like final, any kind of discussions from the group. As well, what I'll also say is we will be sending out a feedback survey, should literally take about 3 minutes following this webinar. If Reese as well, you could also put that in the chat. We'd really appreciate anyone that attended today filling that out, just so we can make sure that we tailor these webinars and make sure that they're useful for everyone to attend. And we want to make sure that you get the most out of these short sessions as possible. So I'll kind of bring the end of the slides there. If anyone wants to raise a hand and discuss anything or ask any questions, feel free to. Again, the Menti should be on screen if you want to ask any questions anonymously. If no one asks any questions after a couple of minutes, I'll turn off the recording because I know some people are more comfortable asking questions with the recording off. So I'll hand over to the room now if anyone has any questions or discussion points. Kate, I can see your hand up.
Hi, Jordan. Sorry, my chest is still very blocked up. I just wanted to say that the 2 year, that migrant profile, the 2 years, I think, yes, students, but also the Hong Kong BNOs will be within that group. So again, that has got to be split up. It can't just be taken as a global or big figure. And there's at least 2 separate groups within that.
Say that again. Sorry, the first bit. Sorry, it's quite quiet on your end.
No, this is because my chest is blocked. Sorry.
Yes, sorry.
Right. So what I was saying was in the demographic breakdown, the group that have been here for less than 2 years.
Yeah.
That group will be split by you mentioned students, but also the Hong Kong BNO visa holders, many of whom will have been here for less than 2 years. So that is 2 totally different groups.
Definitely.
So their health profiles will be different.
Exactly. Yeah. And
a comment rather than a question.
Yeah, no, thank you. I think we kind of mentioned a little bit of that in the full report, but no, you're absolutely right that each kind of demographic data and each health inequality statistic is not just generalizable to everyone. So no, you're absolutely right that populations are split again, and we'll all have completely unique health needs. Just because you identify with the same ethnic group doesn't mean, you have exactly the same experience or health needs. Definitely, thank you.
And there are 2 of the key points, which personally, I don't know whether our organisation will be interested, but it's the ones where there's a sort of there's a statistic about childhood experience, and then by adulthood things have improved. So I'd be interested to know what happens in between.
Me too.
I don't know whether the report looks at that. Probably doesn't. But it'd be interesting to know what the community does for itself that improves its own outcomes.
Exactly. That's one thing I'd really like to explore in some of the upcoming kind of engagement work that we've done, is why some inequalities are seen at childhood and not at adulthood, because there isn't the data kind of show in between. And if there's a particular community trait or habit that kind of helps kind of like self-overcome these, I'd like to kind of promote that and kind of suggest to everyone else, like, look, this is what this community is doing, adapt the same healthily like behaviours that help improve these particular outcomes. So there isn't the information at the minute that says why I can see those differences, but I'm agreeing with you that it would be useful to fill in that data gap to understand what kind of the community does in those years.
Okay, obviously we're very interested in principle in working with you on these matters.
Yeah. So thank you. any more questions or comments? But thank you, Kate, for kind of coming forward with some of those comments. Hopefully they'll be useful for everyone else in the room as well. Can't see any more hands at the minute, so I'm going to stop the recording there, and then we'll have a couple of minutes opportunity for anyone to ask questions that doesn't want to be recorded.